Good morning, and thank you, Sanjay, for the invite. And first of all, to say I apologise if I slip back into any of the old jargon. I haven't quite managed to follow all those new terms we should use. So in terms of my conflicts of interest, this is all about research. I've got lots of different types of research funding. These are my views, or views from the trial team, not the funders. And the third point's interesting, and that as you conduct and report and analyse and think about a large-scale randomised trial, what happens is that you think about it and then your views evolve. So there'll be things and views given that perhaps have evolved over time, and I would say to you all, as you hear data, think about it and reconsider your views, because that is the key with some of these big trials. It takes time to actually think about what they might mean in practice. So what I'm going to briefly do is just go over the headline results, just briefly, primary and secondary outcomes. I'm going to think about the generalisability of these findings to the UK, and this is important when we think about the international previous trials. And then also think about which operation would be recommended as we dig into more of the results, of the more detailed outcomes. And I just remind you that it started a very long time ago. And as we think now about the possibility of a future trial comparing surgery, metabolic and bariatric surgery, with the OMMs, and the obesity management medications, which is absolutely critical to inform decision making in the NHS, I would say to you, we're at that stage now, now in 2024, just at this stage, should we do that trial? I would say to you, as we think about that future trial, and when we first thought about this trial, just the two-group trial, it was actually really difficult for people to sign up to be part of it because it's challenging, and people were a bit shy about saying, I'm prepared to randomise. But the people that did our first step of bi-band sleeve, so they first did bi-band, these guys, who look terribly young, photo from 2011, they were brave, and I've said this so many times, they were brave to do that. So as we try to get a trial off the ground to compare MBS with OMN, my challenge to you all is, are you going to be one of those brave people and be up for participating? Because unless we work together to answer that important question, that really means across the country, across the world, we won't get the answer quickly, and we clearly need to do these things better than before. There's the challenge for you. Well, what's happened? I don't have my full set of slides, so that's interesting. Anyway, so we went from bi-band with the introduction of sleeve, and at the point that we introduced sleeve gastrectomy into bi-band sleeve, there was safety data, definitely one-year safety data, but at that point in 2014 there was no published effectiveness long-term data. So that was why we didn't introduce sleeve gastrectomy right from the outset, because back in 2011 there wasn't even really the safety data there, and there was a lot of learning going on, but at this point we decided to adapt it. But the key thing, when I say effectiveness, I mean patient benefit in the long term. And so we introduced it into our trial then in 2015. But what did happen across the whole country and the world is that everyone introduced this new operation into clinical practice without effectiveness data. And another challenge for you to all is to think, is this the right way for surgeons to change their practice? And I'm going to come back to that point, because it is critical to how we introduce things and what we tell patients. And the ethical side of that really is critical. So, because we go on this assumption that you's better, and we can't help it. It happens not just in surgery, it happens in way outside medicine, but there's this inherent optimism bias about new things being better. And we do need to have a responsible way of doing this, and at the moment surgery is very different to the introduction of new medicines, and we can just introduce things, and that's one of the big questions we need to think about. So we did it. The people that took part in the trial did it scientifically. Every patient that was randomised were offered the 3 procedures. They were given balanced information provision because no one really knew their effectiveness, so it was ethical to randomise them. So at the point of randomisations, those patients gave consent to be randomised and received one of the 3 procedures. Outside the trial, most people were beginning to be offered sleeve or whatever, and maybe those conversations weren't as So roughly we thought that the weight loss might be similar between the three groups based on historic data. But we hypothesised along the rest of the world that sleeve gastrectomy would be better, would be superior to bypass in terms of quality of life and weight, of course, would be superior to that. So that second hypothesis, which was part of the co-primary endpoint, reflects the optimism bias that everyone had about the new procedure. Even we, the sort of slightly more sort of Luddites, the trialists, if you like, thought sleeve was going to be better because everyone said it would have fewer complications, just as good weight loss, and that would result in better quality of life. And as you know, it would not. And this is the key about biband sleeve that makes it so different to the earlier trials, to sleeve pass and to sleeve bypass and to SM bots. The big difference is this large number of hospitals and surgeons that took part. So the other trials, they were either 2 or 3 or 4 centres, and they weren't anywhere near so many surgeons taking part. And some people would criticise that and say it makes it messy, but it also makes it much more reflective of real-world practice. Because would you look at those centres, and you know the teams, some of the teams are here, and would you say that the surgeons in those centres are less good at doing sleeve gastrectomy than other surgeons across the world, or than doing bypass? And they're very representative of UK practice. And to have such a large number of people involved means that the results really do reflect what will happen in the future, well, when people are outside a trial. And that, I think, is one of the key strengths of biband sleeve. So we did go through all this enormous piece of work, screening people, talking to them, randomising them, following them up, huge amount of effort. 100-odd patients never went on to have surgery. Sometimes that was pandemic related because the tail end of the trial was in the beginning of the pandemic. And then we followed everyone up to 3 years, as you know. And the baseline data, so the representativeness of patients in biband sleeve, which I'm going to come back to because it really influences the outcomes. The key ones are shown there. So 75% of our included participants were female, mean age was 47, that's older than the other trials. And we are the first trial in the world that has presented the ethnicity data. And again, another credit to those teams that did the recruitment. This ethnicity data is completely representative, almost completely representative of our UK population. Most trials don't even mention what the ethnicity breakdown. Most previous trials in other areas tend to only recruit Caucasian white people. And yet, as we all know, this is a really serious issue, and we do need to know how these different treatments work in the different ethnic groups. So I'm particularly proud of the fact that the teams worked hard to make sure it was inclusive. Our patients, as you know, in this country were heavier than other centres because we get to bariatric surgery so late. And the other thing that's really key about this is that a third of participants were diabetic or on medication for diabetes. So it really is representative of UK practice. And again, people don't always include diabetics in trials, but a third of them were. And I'm going to come back to these figures as we think about millions of outcomes. So we've got this, briefly the headline results, then some more detail about quality of life data, and then some other issues around liver function, liver fibrosis, sleep apnea, and the sleepiness scale, and binge eating disorders and dietary outcomes. There's so many outcomes in biband sleep. We've had a bit of a nightmare trying to write it all up, and the paper will be shortly, we hope, it's almost accepted to come out in Lancet Diabetes and Endocrinology. And perhaps the thing for you to all look at is the supplement, which is 80 pages long. The paper's the usual 3,500 words, but the supplement's got 80 pages of detail. And all these things will be detailed in there, and it's just been wonderful. So the weight loss findings, you know, and this is the old-fashioned percentage excess weight loss. And the big thing that's new about this is that our data for the first time showed significant differences between the groups. And the key issue is this big difference between bypass and sleeve is so much better in terms of weight loss. And here's our percentage. Total weight loss with significant differences between the three groups. And then when you try and further test that, stress test that in our pre-agreed subgroup analyses, so you look to see whether diabetics fared differently to non-diabetics, we found the same pattern of weight loss in in both of those groups and between the different baseline BMI categories, the same pattern. And so when you then compare this with the other trials that I mentioned, these are the three only other randomised trials that reported the long-term 3 to 5 year data. You look at the differences, you try and pick out why did our patients undergoing a sleeve gastrectomy have not such good weight loss as the other trials? And this is the question I'd be interested to hear your views. Is it because the patients were different? Is it because we did the surgery different? We need to work out why. The reviewers of this Lancet paper keep asking me that question on the second lot of reviews. And you can see that our patients are heavier, not the other trials have fewer proportions of people with diabetes. And when you look at their outcomes, the percentage, the mean reduction in weight loss for the sleeve in the BBS group on the left, it's very different to the other trials. So the question is, why is the weight loss in the BBS patients and the sleeve gastrectomy group so different to the other trials? And I can't explain it. And I don't think it's because the standards of surgery were poorer in the UK. I think they're more representative of the general standards, as I said already. And we did monitor adherence to the study protocol. I think our baseline differences, whilst there are some differences in the patients, they're not huge differences. We have got a good proportion of ethnic minority groups. We don't know what the ethnic minority split is in the other trials. Whether it's that or not, I don't know. Interesting. That's an outstanding question. Quality of life reflected the primary outcome, wasn't statistically different in the generic one, and the metabolic health outcomes favoured bypass. It wasn't always statistically significant. You'll have seen these results before, the cholesterol differences shown there, and then the blood pressure differences. But very much more benefits to bypass in terms of becoming more intensive at 3 years. These are more detailed quality of life data. Our patient group, our patient advisory group, chose which aspects of health-related quality of life to test for, because there's loads of different parameters we measured, and they chose well, I think. So we have the physical component. So there's no doubt bypass wins again, but it was not a significant difference between sleeve and bypass. Mental health scores, no differences between the three groups as per other study findings. The iQual Lite, which gives you an obesity-specific overall quality of life score, showed clear differences between the three groups, which is really important because that's more focused on issues related to patients living with severe obesity. And the patients also wanted to test for reporting of self-esteem, and this was significantly different between the three groups. So perhaps to think about is, should you be sharing these data with your patients at the point of talking to them about sleep or bypass? It would take a bit of effort, but these are large numbers of patients and there's significant differences. Sexual function, no difference between sleep and bypass. GI symptoms, including reflux disease, we didn't find differences between the three groups, but we haven't sub-analysed the reflux scale on its own. Then when you dig into more detail in terms of liver function, here's just ALP and bone impact and ALT. There is, as we know, after gastric bypass, you get a much raised ALP, which indicative in the long term may show trouble, which would need to be looked at in the long term data. And we use the ELF test, which is a non-invasive measure of liver fibrosis that can be used. And we didn't get data on the whole cohort, but 22% of the patients, that was nearly 300 patients, had baseline and follow-up data. And on those samples, just looking at those samples, there were the same proportions in each group. It's very interesting. We found that at baseline, only 14% had mild disease. Most people had moderate disease. And at 3 years, the increase in proportion of patients with severe disease increased across the whole group. So we know the whole group had lost a lot of weight. So whether this shows that bariatrics, metabolic surgery, is somehow mediating the impact on the liver fibrosis, we don't know, but that would be interesting to follow up in the long term. In terms of sleep and impact on sleep, we use this validated measure, the Epworth Sleepiness Scale, which asks you these 8 questions, and there are 4 responses. It's 15 minutes, I won't be much longer. And here's the kind of normal scores, where I fall into, I struggle to nod off. And then if you look at the mean scores at follow-up, the three groups were very similar, and the majority of people weren't suffering from problem C. In terms of CPAP and BiPAP, there's a big impact, a big reduction in all the three groups. If you look at the 36-month follow-up there, you go from 23% to bypass down to 12%, but it doesn't get rid of it altogether. And then the binge eating scores, which is clearly an important issue for patients. If you look across the three groups at 3 years using a validated binge eating measure, you can see that they're not that different, and the stats around it doesn't show any significant difference between the three groups. Oh, and bypass, band is always coming out worse, but I'm referring to sleep and bypass. Okay. So the last two slides, the dietary intake scores, again shown here, are not particularly exciting between the groups. So just to summarise, yes, gastric bypass does lead to significantly more weight loss than sleeve hysterectomy, and on the whole, other benefits, some are favoured and some significant benefits. But the key things to think about, and we will be now investing in getting a good team together to do the long-term follow-up, the key things to really find out whether these effects are maintained. And my challenge to you and to surgeons across the UK is, how should we